Why do diabetic folk die? They die for all the same reasons that the rest of us die. But there's the vascular disease. They're more prone to get vascular disease. They're more prone to get dementia, 2 to 3 times increased risk of dementia. And we'd like to try and avoid that. So if you keep the blood pressure down and if you avoid hypos, you're probably going to decrease the chance of them getting dementia. So the question is it straightforward? And in one way, it is. We're doing what we do all the time. We've got some intervention. Will this intervention do more good than harm? Full comprehensive assessment, assess one's intervention. But I think it's quite difficult. There are no randomised controlled trials to speak of. We've known these folk for a long time, so it's actually quite difficult. And we're entering palliative phase of their care. It's us appreciating that, it's everyone appreciating it. And I find if you've looked after someone for a long time, you sometimes find it's difficult to change mode. And the patients and everyone else get very upset because for the last decade or more, we've been concentrating on numbers, blood sugar, cholesterol, blood pressure, but now we're saying actually that doesn't matter too much. And we're trying to decrease the number of invasive tests, but at the same time, we don't want them to go hypo. Timing of this, we're all dead in the long term, but one can look at it as dying over the next 6 to 12 months. And I was heartened by Clive's talk this morning. In our folk going into nursing homes, the survival isn't that long. And Roger Gadsby's paper in Diabetic Medicine shows that most general practitioners would be surprised if any of their nursing home residents lived more than a year. And in these folk, we're trimming the tablets and treatment as we go along, and there are those that are dying within the next few days, and we're withdrawing non-palliative treatment. So we want to try and spot those that are deteriorating, and these are the ones that are losing weight, multiple morbidities, although most diabetic folk will have multiple morbidities. And to me, these are the ones that are coming in and out of hospital frequently. We're treating them, but they're not really getting better, and if anything, they're getting worse. Those are the ones that I think aren't going to be here in a year's time. Now, wherever you work, there will be someone in your trust who has designed or is designing a protocol. So they're probably all reinventing the wheel. In our trust, Colette Reid has done a protocol which we use all the time. It's superb. It's got all the different drugs, all the different doses. I can never remember which variety of hyoscine to use, but Colette's chart tells me. It also has a tick box of symptoms, so we can see if the person is distressed, agitated, in pain, difficult secretions, and this tick box exercise means that the problems get addressed. It really isn't a problem with complaints, but if you use the tick box exercise, then if there is a complaint, you have the evidence that you looked and you tried to address the problems. Now, in essence, end-of-life care in diabetes, we're removing unnecessary drugs, we're covering up symptoms, and communication is really important. So patients with the family, with the healthcare professionals, and hopefully not with the coroner. So we want to be in charge of the situation the whole time. We want to be setting ceilings of treatment. And I think we should use email more often. It probably varies from area to area, but most of my patients are very happy for me to communicate with their GP and with their family members via email, even using non-secure email accounts with the family. Our diabetic objectives are to avoid symptomatic high sugars, to avoid DKA, to avoid HONC, although one should call that hyperosmolar hypoglycemic state now, and to avoid hypos. So we're really stepping back big time. And if you're doing that, it's really crucial to know if someone has type 1 or type 2 or secondary diabetes, because if they have type 1, they'll always need a small drop of insulin, but if they have type 2, you might well be able to withdraw the insulin if they're on it. It really is a case of going back through the medical records and grilling the family if it's not clear. In other folk, we do fancy tests looking to see if they've got some insulin function, some beta cell function, but it's just not appropriate in the palliative care person. And relaxing the targets. So 5 to 15 if you have a 5 to 15 target, we think you'll avoid hypos and you'll avoid symptomatic hyperglycemia. And then if they are unconscious, you've really got to check they're not hypo, and then we stop testing and just continue with a palliative approach. Now, type 1 diabetes, we've got someone, they've got type 1 diabetes. These are the guidelines from ABCD, which are useful, and basically want to try and relax treatment and simplify treatment. We'd probably want to move away from a basal bolus 4 times a day regime, but actually some of the patients still like it. And we've had a few folk over the years who said, I've just had enough, doc, I just want to stop the insulin. And if they're mentally competent, then it is very reasonable to do this. This is the person's desire, and the only thing we would do is we would get a second opinion. And in the type 1 diabetic person on insulin, we'd be trying to cut the sugar testing down to once or twice a day. What else are we going to do with these insulin-treated type 1 diabetic people? So the more complicated regime, we're trying to reduce it to once a day long-acting analogue, or twice a day ready mix, or twice a day NPH insulatard type things, and reducing the insulin dose before they go hypo rather than after. And so you can't do this unless you do have blood glucose levels from finger prick tests, unfortunately. And basal dose is usually half the usual insulin dose. And so if you've got someone who's been on insulin and they're losing weight and not eating very much, half of their usual insulin dose is their basal equivalent, and knock it down a bit further just for safety, because you can keep an eye on them and you can increase it if necessary, but going hypo is exceptionally unpleasant. So, moving from type 1 to type 2, the tablet-controlled person is often able to come off the tablets as they lose weight, and the insulin-treated person, we can often take the insulin away. So in summary, palliative care in older diabetic folk is a very, very common problem. There's very little evidence upon which to base our treatment. Most of the evidence is actually sort of physician surveys. You've really got to know the type of diabetes. You've got to look at the person, and as they're losing weight, going off their food, you've got to be decreasing their treatment. And at the end of the day, it's common sense. One size doesn't fit all. It's a case of suck it and see.